So anything goes terrible here in a few minutes. That's not great. I'm hoping it will. All right, guys, can you see me now? Looks like there's not many people left. Let me know if you can hear me, see me, any of that. Let me know if you guys can hear and or see me by any chance. So it looks like it's working. Okay, there you go. All right, fantastic. All right, sorry about that. Technical difficulties aside, we're going to continue on. All right, so starting the recording again. Let me know if things drop out. But anyway, so I was trying to show you guys a new paper that actually just was published online, I think today actually, and it's interesting to watch the COVID stuff like kind of really rapidly develop over time and to see how things change from moment to moment. This is actually a paper that has not even been peer reviewed yet, but the importance of getting it out was such that they felt that it was appropriate to go ahead and at least let the information be out there, with the caveat that it could be redacted, it could be or not redacted, it could be removed, or there could still be some edits or something like that. But anyway, they think it's like the biggest study so far they've done looking at using hydroxychloroquine for COVID patients. And so this is actually done in a French, done by some French authors, and they actually ended up having 181 patients. So it's still not like a huge number, but it's, a lot bigger than, say, what we've been dealing with thus far, or at least with the anecdotal sort of evidence that we've had previously. And so I just want to show you a few things here. I'll go down to the tables. I think it's a little more interesting. So, but essentially what they were finding is, the two groups, whether they got hydroxychloroquine, which you can see here, versus not, they're pretty evenly, the two groups are pretty similar to one another. But what you can see here is we're looking as a primary outcome, they're looking at death or transfer to the ICU, and they were looking at between the two groups here, so roughly equivalent. They had 16 people either had to be transferred to the ICU or die that had documented COVID-19 that received hydroxychloroquine within like 2 days, versus 21. And you can see here the relative risk. And as you will recall from taking the biostats class, you can tell that this is a non-significant value here. So even though it looked like maybe hydroxychloroquine maybe had a little bit of help, it's not statistically significant. And they also looked at mortality, which again you can see here is not statistically significant. And then finally the occurrence of ARDS. So interesting that it looks like maybe there's not, at least from this particular study, any evidence to show that hydroxychloroquine actually helped. I guarantee we're going to see a lot more of stuff like this to come, but I thought it was interesting to, at least to point out and show you just how quickly some of these things are changing here. So anyway, so enough about that. Let's get back and talk about our snakes. Does anyone have any questions about the stuff we covered already? Remember we were talking about our Crotalidae, the pit vipers, and how you can identify them and how they cause significant coagulopathy and a lot of swelling and tissue destruction. Well, now we're going to be transitioning over and looking at the Elapidae. And so this is where primarily you're going to see the eastern coral snake. And the eastern coral snake is really the most like toxicologically most sort of relevant snake, at least here we have in Florida and for most of the U.S. actually. And if you look at the Elapidae family, in general, you kind of can include a lot of things like cobras are kind of similar and whatnot. But here what we have in Florida is the eastern coral snake, and of course the easy way to remember this is using the mnemonic red on yellow, kill a fellow. And so what that means is basically if you look at the color banding pattern and you want to look at the body of the snake, if you see red on yellow, that means that it's going to be a eastern coral snake. That means it's venomous, and we'll look what that venom does in just a few moments. And then red on black, venom black, or red on black, friend of Jack, whatever you want to use there. Those are going to be non-venomous snakes. So if you look here like the scarlet king snake, otherwise physically they look very similar, so you couldn't tell with like the pupils, you couldn't tell because of the shape of the head or anything like that. It really all goes back to the color banding pattern. So what's interesting about the coral snakes too is that they don't have those big hypodermic needles for fangs like you would see with the Crotalidae. These guys have these kind of rear hinged fangs that the patient, or not the patient, but the snake really has to like bite onto the patient and really hold on there and kind of chew before it can really inject the venom. And so you're going to see that there is a high proportion of dry bites that can occur with these particular types of snakes. The thing that's interesting is the fact that it's a neurotoxin. So basically the thing that would really kill the patient is eventually they can develop diaphragmatic paralysis. Essentially it kind of works to block acetylcholine receptors and will cause, initially like some paresthesias and maybe some numbness and the fingers wherever the bite happened to be, but eventually it will travel, closer to the respiratory tract, and that's where you can see that paralysis occur. So these patients, they frequently, if they don't receive treatment, frequently need to be intubated because they do end up developing respiratory failure. Really not a whole lot of local effects you're going to see, maybe a little minor swelling, but the thing with these guys, whereas with the Crotalidae, you could watch those patients for 8 to 12 hours and see if they became symptomatic, and then you could determine whether it was a dry bite. If no coagulopathy occurred, if no swelling happened, you're good to go. With these guys, though, because you can have a really delayed presentation, it may be up to 18 hours in some cases before patients will be developing symptoms, we actually go ahead and we have to watch them for 24 hours essentially. And this is frequently going to be like an ICU admission, just to have the nurses be able to do those frequent neuro checks to make sure they don't develop any sort of weakness, ptosis, anything like that could be indicating that the neurotoxin is setting in. So it's kind of tough. One of the things that we will ask patients about when they have the bite too, we'll say, well, did the snake, when it bit you, did it bite and fall off, or did it sit there and did you have to pull it off? And they say it kind of sounds like Velcro when you pull it off, if that paints a better picture in your mind. But basically what that means is if a snake, bites you and then falls right off, that's typically like a warning bite, from a eastern coral snake, because they're not looking at you like your food. So in those cases, it's typically no venom has been injected. Whereas if it sits there and chews and is able to inject that venom, that's more concerning if they actually had to pull the snake off. And so I'll tell you kind of a funny story. It's one of my favorite snake stories I ever had. Was we had this guy who we came in the morning. We were going to go round on our patients. And basically the night before, he was out in backwoods Georgia somewhere. It's close enough to the Florida border so that when he got bit, he eventually was life flighted over to us. But this guy, he was, probably had, maybe like 3 teeth in his head all together, real backwoods kind of salted earth kind of guy, right? And so basically he was in the ICU, he ended up getting the coral snake antivenom. But I was asking him, I was like, well, kind of what happened, that led up to the bite? And he goes, well, I was walking along in the woods and I found this snake and it's all colorful and I picked him up and the little sucker bit me. And I was like, oh, okay, that makes some sense. Did it hold on? He goes, nope, fell right off. And I said, okay, well, that doesn't sound like you would have needed to get the antivenom. Like, doesn't sound like you would have been that symptomatic. And he's like, well, the second time I picked him up, little sucker bit me again and fell right off. And I said, okay. And then the guy goes, the third time, though, that guy really sat there and held on, and I had to pull that sucker off. I said, okay, so the snake gave you 2 chances to walk away, and he didn't take either of them. So that's a pretty typical story you'll see for a lot of snake bites here. But anyway, getting into the effects here, like I mentioned, it being a neurotoxin, you can expect to see neuromuscular weakness associated with this. But other things you can get, including fasciculations and that respiratory paralysis, is what we're really concerned about. And as I mentioned, the effects could be really prolonged. And so actually, I did a lot of my research when I was in fellowship on coral snake bites, because it's not something a lot of people do, because we get the most here in Florida. We maybe get like 50 to 80 a year. And when patients have to be intubated for this stuff, they're intubated for like 8 days on average. And so it was one of those things where it was really clinically important that we make sure you manage these patients quickly, because if there's a delay, then they could be on the vent for quite a period of time. And so, but the paralysis is reversible. It'll go away eventually with enough time. So, as I mentioned, you got to monitor patients. They have to be asymptomatic for 24 hours, usually up in the ICU. So it's kind of a guaranteed admission for those patients, even if they are asymptomatic. And again, the first aid measures, like just clean it. There's no prophylactic antibiotics. We don't want to do any kind of like tourniquets or anything like that. Just go ahead and get them into the ER as fast as possible. Once they're there, again, you can assess for the tetanus status, make sure that's up to date, and look for any allergies. This is another one we really want to ask about previous administration, and we'll look at why in a second. But the risk for having a reaction the second time you receive this antivenom is a lot higher than we'll see with something like the Crofab or the Anavip that we saw for the Cortality last time. And again, treat the pain and anxiety if any of those are present, if need be. So there's actually a big update to this slide here, because for a while we actually didn't have access, or the coral snake antivenom was no longer being made. It was kind of interesting how the company said, well, I think there's an issue with their production, and they went ahead and just shut it down. But basically this is an equine-derived antibody, and whereas with Crofab it was just the FAB portion, or Anavip, which is like an FAB2, a little bit bigger immune globulin. Here you actually find this is the full antibody, right? So basically they hyperimmunized horses, and then they separated that out, and then we can now administer it. And so for a while it was not being manufactured, and actually all of it had gone out of date, but every year the FDA would come in and test it to make sure that it still had still retained efficacy, and we'd still continue using it. So nowadays, actually, as of 2019, it is now being produced again, which is a really good thing in case you ever get bitten by a coral snake and you need it. And so with this one, again, we basically, if patients become symptomatic, we'll give them between 3 and 5 vials, depending on how severe it is. This is one, though, whereas with like Crofab, because it was ovine sourced and patients aren't likely to have as much of a reaction with a little FAB portion of that antibody, you didn't have to skin test for it. You still monitor for anaphylaxis, but you didn't have to test for it. Here, though, you have to skin test, and basically we end up taking a small amount of the antivenom, we dilute it down, and then we do like a little subdermal bleb. And if you see a wheel and flare reaction, then you know that there's a risk that patient's going to have a severe systemic reaction when you administer it. And so in those cases there, it's like one of those things where it's like, well, do I just not treat them because they had a reaction, or because the patient probably needs it? In those cases there, again, you have to kind of treat through the anaphylaxis in some cases. So you may have to use your epi and your steroids and your Benadryl. If they do have like a subdermal or intradermal reaction, we would definitely pre-medicate with them anyway. So definitely giving some steroids and Benadryl for sure. This is another one where you're certainly going to see serum sickness happen pretty commonly after the fact, and it may show up maybe 1 to 2 weeks after they receive it. That's kind of a delayed reaction to your body's own reaction to that particular type of venom or antivenom. So if there's any questions on that, feel free to post them up in the chat or on the sticky board. We'll talk about some other random critters here that you will run into in Florida. And so caterpillars are something that a lot of people don't think about as being a particular issue. However, they can be quite painful. And so there's 4 varieties that you're going to see in Florida. There's things like the saddleback caterpillar. There's the pus or the puce caterpillar. There is the Io moth, and then finally the hag caterpillar. So someone must not really like that one to name it that. But basically, what we're seeing is that they have these little tiny spines on their back, and once those spines actually get into the skin, they are quite painful, because not only do you have like the actual physical trauma happening there, but they also have these toxins that can be released, and they can be, one of the things we always talk about is like pain out of proportion to what it looks like. And so I'll never forget this one patient who came in. The guy was probably like 14 or 15. He was sitting in there in the ER, and just the reason for visit was a caterpillar sting. And I mean, the guy was crying. He was in so much pain, and the mom's like, he's faking it. He does not really feel that, like he's in that much pain. And it took about 2 rounds of morphine just to get him under control in terms of his pain. And finally I was just like, no, this is legit. And the mom just still couldn't believe it. But yeah, so quite painful. And so other things you can see as well at the site is some swelling, some erythema, but for the most part you don't see a whole lot. The pain can be so severe that you actually can end up vomiting from that as well, so it's something you may want to watch out for. And always, if there is risk for eye and throat contamination, that can also be a challenge as well. Some people may have an allergic reaction, but it's fairly rare. So the question is, how do you deal with that? And so this is another one where decontamination is really important. And so this is where, duct tape fixes everything, as they say. This is actually one of those cases where it can be quite useful. And so basically you can take any sort of adhesive tape or something, duct tape works just fine. And you can use that to put over where the sting happened and then pull that off. And that should help to remove all of those little spines out of the skin. And again, you help to eliminate any further exposure, and then you can wash the soap and water afterwards. If there's any sort of itching or redness, things like that, you can certainly use antihistamines. And then pain management is really the big thing here. So you can try NSAIDs, if they're in the office or the clinic or ER. Toradol may be appropriate here, but like I said, this guy needed, I think, 4 milligrams of morphine in total just to get his stuff under control, his pain. So again, pretty straightforward, but it's one of those things where if you don't know about it, then it may kind of take you by surprise. Next, I want to talk about spider envenomations. This is something where most spiders actually are not able to, even though they are venomous, they don't actually have the fangs really to break through human skin. And so in Florida, though, there's two main varieties that we actually care about. So in terms of being clinically important, there is the Lactrodactys mactans, or the black widow, and then there's the Loxosceles reclusa, or the brown recluse. Another name for this one is the fiddleback spider, and you can see the little fiddle sort of shape there. Again, I wouldn't recommend getting close enough to where you can actually see that, but if that's your thing, I say go for it. As I mentioned, most of them cannot penetrate human skin, but certainly the brown recluse and the black widow are the ones that can cause clinically important reactions. And so it's really difficult to determine whether patients were actually bitten by a spider in the first place, because most of the time they don't actually even see the spider itself. They just, they wake up one day and they have a big red bump on their butt or something. They say, oh, it must have been bitten by a spider. Well, you probably have a MRSA infection. It's probably, a skin infection there. So we always joke about there's the MRSA spider that goes around biting everyone, giving them abscesses. But if you do have the spider to identify, that certainly helps out in terms of making your diagnosis there. And also there's a lot of propagation of misinformation. So, anytime someone has an abscess, they say, oh, it was a brown recluse that bit me. It's well, it probably wasn't. It's actually pretty rare that you see a lot of these cases pop up. So getting into the black widow first, certainly there's a lot of varieties, and you always think about looking for the ones that actually have that red hourglass on their abdomen, but there's other varieties as well. There's brown widows and red widows and all these things here. Here's an example of a southern black widow, and notice how the coloring is much different than what you kind of classically think about. Typically it's the females that are responsible for bites because they happen to be much larger than the male widows happen to be. And you find these quite frequently in places that are maybe not used all the time, outdoors, a lot of outdoor restrooms and garages and things like that. And typically they're pretty shy, but it's when you're maybe you're going and cleaning up, or you put your hand somewhere and didn't realize there's a nest, that's when these bites typically happen. And so if you were to actually compare a snake venom versus the spider venom, actually it's a lot more potent with the spiders, but it's just that they're so small, they typically don't inject nearly as much as something like an eastern diamondback could, for instance. But there's a lot of active components. Alpha-lactotoxin is the main one that we care about. For the most part, you'll see with the actual bite itself that it's pretty painful, and there should be a set of red spots that will develop, so that kind of indicates, it's probably an actual bite here. But the local effects are generally pretty limited in terms of that. So this is going to be another one, though, that actually causes a lot of pain that's out of proportion to what it actually looks like at the site of injury. And so this alpha-lactotoxin, what it does is basically causes all these cation channels on the skeletal muscle to open up and allows for this big influx of calcium. And as you might imagine, calcium coming into skeletal muscle causes calcium to be released from the sarcoplasmic reticulum, and that causes the actin and the myosin to come together, and boom, you have contraction of the muscles. So cramping is going to be a really big thing you're going to see here, these muscle cramps. Not only that, but you can also end up having release of things like acetylcholine and norepinephrine and whatnot, and so that's also going to be leading to a lot of the effects you're going to see with this. And so, as I mentioned, the term for a black widow envenomation is actually the latrodectism. And so, usually within 30 minutes to 2 hours or so, it'll become symptomatic. And by 3 to 4 hours, you get really painful cramping and fasciculations that can happen here. And typically, you get this kind of very rigid sort of muscle that can develop there. And depending on how big of a bite it was, you may see it travel to some degree. So looking at this other effects you can see, in some cases you can see things like hypertension occur here, tachycardia associated with this. Again, it's all that acetylcholine and norepinephrine being released, nausea, vomiting. Very rarely you're going to see things like respiratory arrest. The most severe ones that I end up running into are typically either like pregnant patients or patients at the extremes of age. I've had one case where like an infant was bitten and they got severely hypertensive, and that'll be important for the management, which we'll look at in just a moment. Basically, though, good wound care, soap and water. If they need a tetanus update, make sure to do that. And then again, this is going to be pretty painful, and you can try a couple of different things. You could try something like IV calcium. They've talked about using that in the past, and it has some transient benefit, but for the most part, you're either going to need like a muscle relaxant, like a benzo, like diazepam, or maybe morphine or other opioids as well that could also be used here to get that pain under control. There is an antivenom available. It's another equine-derived antibody, but it's very rarely, if ever, used. Mainly because most patients can be managed symptomatically, and the risk for anaphylaxis is high enough to where you typically don't want to bust this out if you don't really need it. But as I mentioned, either the very old, the very young, or pregnant patients may be symptomatic enough to actually warrant this. And so this was a case where that infant I mentioned actually ended up getting the antivenom. That's the only time I've ever actually seen it administered. But they administered it very quickly. The muscle cramping went down, and you end up seeing the blood pressure come back down, and the kid did totally fine. Usually then 24 to 40 hours, though, the patients will have recovered. But keep in mind, try to ask the history, try to see, do they actually see the spider? If not, always have a bit of a skeptical eye towards whether or not you actually expect it to be a real, true bite. If it looks like this, so if they're having that muscle cramping, if they're having local sweating, all of that, like that makes it seem much more likely. And then here's an example of a non-venomous spider. So just in case you ever see one of these. And then getting into the Loxosceles reclusa, or the brown recluse here. What's interesting is the brown recluse actually is not really indigenous to Florida. Depending, if you look at the maps, you can see that it typically doesn't thrive here. You can see hitchhikers that will have isolated nests. So if you go out like camping up in Georgia, maybe you pick one up and bring it back down potentially. As I mentioned, they're called recluses because they're reclusive by nature, but they typically, you're going to find that if bites occurs because someone was not looking and they put their hand somewhere or something like that, but it gets blamed for a lot more bites than it actually causes, mainly because people get an abscess and all of a sudden they think, oh no, it's a brown recluse bite, when really it wasn't. Here's an example of what that fiddleback looks like. Again, you have to get pretty close to see that, so I would not recommend that. So the reason why the brown recluse gets such a bad rap is because its clinical effects are quite severe, quite interesting to look at. Basically, its venom contains a lot of components, but the two primary ones you look at are things like hyaluronidase and then this sphingomyelinase D. And so what you're going to find is that basically it causes this local tissue destruction. It's called a red, white, and blue sort of wound that occurs, kind of like a bullseye kind of lesion that happens. And so you end up getting, over the course of 1 to 3 days or so, you get this necrotic ulcer that forms here. And there's not a whole lot you can do about that. You can try to cut it out, but if there's any bit of the sphingomyelinase D still around, it's just going to get further into those margins there. Not only that, but the other thing we really are concerned about with really severe reactions is that you can see the systemic hemolysis that can occur, and that's another thing I've seen more frequently in small children. Maybe infants that have been bitten before, they are more likely to see that potentially. But for the most part, it's just good wound care. I mean, some people have looked at things like hyperbaric oxygen to see if that may help out, but for the most part, not a lot you can do with this. And again, as I mentioned, the systemic effects is called loxocelism, and that's where you can see the malaise and myalgias, but that intravascular hemolysis can be really potentially deadly unless the patient gets replacements potentially. So in terms of treatment here, again, ABCs, wound care, tetanus prophylaxis, you can see is pretty similar to all the other critters we've looked at already. There are some people that look at the use of the drug dapsone to be used here for these necrotic ulcers, but there's not any kind of conclusive evidence to show that it really helps. And in terms of other therapies, there's no anti-venom available, and there's no reason to excise it. Like I mentioned, hyperbaric oxygen can be useful because we use that a lot for other types of wound care, but really it's just tincture of thyme is going to be the best thing to help manage that. So that's it for the spiders, and then moving on, we'll talk about our marine envenomations. So this is where you have guys who join the military and then they bite somebody. I'm just kidding. I'm talking about water-based envenomations here. First one is going to be the Cnidaria we'll mention, and so basically this is where you get all of your jellyfish essentially. We call them, or basically they end up having what they call these nematocysts here, and so this is where you can see that here's the kind of the unfired sort of nematocyst versus when it actually fires it off, and so basically it fires off this little hollow barb that has venom in it, and so we can see that these will be firing off for a lot of different reasons, and I'll talk about this and why it's clinically important in a little bit, but changes in pressure or osmotic changes, different types of chemicals can potentially even cause this to fire off, and we'll see that they are quite painful in just a little bit. There's a lot of different varieties, and so I'm not going to get too much into the weeds here. I will talk about a few ones that are particularly dangerous you may see. Not all of them may be in Florida, but I mentioned them just because I think it's interesting and it's good to know about in case maybe you're practicing in Australia. Who could say, right? So talking about it first, we have the cubozoa, which are not true jellyfish, but they still fit into this family of Cnidaria. These are actually the most deadly ones that are out there, and these are ones you think about, like Australia being really dangerous and everything's out there to kill you. That's where a lot of these end up at. But these include the box jellyfish and then the Irritant jellyfish. You can see them here listed respectively. Next we have the hydrozoa. These are also not true jellyfish. You will see a ton of these in Florida for sure. These include things like your Portuguese Man of War, which is kind of listed here, and things like the blue bottle jellyfish as well. And you can see their tentacles can be quite long, so it's possible even if you're not at the body of the animal, it can still potentially sting you. Some other ones here, things like Scyphozoa, the true jellyfish. These include things like your lion's mane and sea nettles, and then you have your anemones as well. They can potentially cause a stinging. So for any of you Finding Nemo fans, there is your nice little clownfish who is able to live in the anemone with no problem, right? So what happens here? Basically, you can see with the toxin that can be injected by these nematocysts, you can see tissue destruction potentially, and in some rare cases, you can see things like cardiovascular collapse. You can see nerve conduction being blocked, and so I'll talk more about the specifics of that as we get into the individual animals there. The Irritant jellyfish also causes really interesting catecholamine release, and we'll talk about the clinical findings you're going to see with that, and you can probably already imagine what some of those might be. So normally what you'd expect to see, and again, for the most part, systemic symptoms are not expected to be seen, especially here in Florida with the common jellyfish you're going to run into. Box jellyfish and things like that can really cause severe pain. For the most part, though, you're going to get this pain and erythematous sort of linear rash. If you see that, that kind of makes sense that it would be something like a jellyfish, right, where the actual nematocysts were firing off there. Other systemic effects you may see somewhat more commonly can include things like nausea, vomiting, muscle spasms, and whatnot, but for the most part, you're really just going to get the local effects there. So in terms of the box jellyfish, some interesting things that can happen with this one, and this is one, even though they put up nets and things like that to try to prevent exposures, this is one people can actually end up like dying out in the water after a sting has occurred, mainly because they can end up developing issues where their nerve conduction is going to be inhibited, and they can have things like paralysis and syncope, and if you imagine being out in the ocean and that happening, you're probably not going to last very long. But even things like renal failure has been seen, pulmonary edema, most of those patients end up not being able to make it to shore potentially, and children tend to be more symptomatic when they get stung. The Irritant ones are really interesting because they cause this catecholamine surge, and so they cause a lot of like tachycardia and hypertension and all these things related to having all these catecholamines being released here. And they also end up getting these like really severe back spasms that can occur, and this impending sense of doom, which I mean most of you probably get this right before, like say for instance your test on Monday. Keep in mind though, it's not a jellyfish, it's just me that's causing that. So I guess I share some features with a jellyfish. Getting into the Portuguese Man of War, these are things you may see more commonly in Florida, as I mentioned here, but definitely skin necrosis, severe pain can be seen. And again, the systemic effects are not as common, but these are things I've seen in some rare cases. So things like, vertigo and hemolysis and all of that, not common, but, especially the extremes of age are more likely to see some of these really severe symptoms. Here's another one that's kind of interesting. This is called sea bather's eruption. This is basically this larvae that can be picked up when you're actually in the water itself, and so it causes this papular eruption that occurs. And what normally happens is that these little larvae will actually be picked up in the bathing suit itself, and so this typically happens when patients use the same bathing suit like from one day to another, and they put it back on, and you'll see that the actual symptoms occur right where the actual lining is. So especially if there's like elastic in swim trunks and things like that, you'll see it right there on the waistband. You can see here in this patient here where her bathing suit top was pressed against the skin, had the larvae, and then it causes that eruption to occur. And again, typically you treat it supportively, right? So again, a lot of antihistamines, maybe corticosteroids if need be, NSAIDs, Tylenol, all those things that you can think about for like usual common sort of pain management and kind of allergic reactions. So the one thing I do want to make sure you note here is that you hear a lot of urban legends and things like that about how to actually deal with the tentacles if they are still on the patient. Like, what do you do about that, or what do you do once you have a sting that can occur? I'm sure most people haven't heard things like peeing on it helps with it out. I mean, that may be a good test to see how much your friends actually like you or not, if they're willing to pee on you, but I would not recommend it in a lot of cases. And that actually makes clinical sense based on the fact that the stimulus for these nematocysts to fire off is things like changes in osmolarity, changes in pH, and things like that. Well, guess what? Things like urine and ethanol can actually enhance that discharge. And so there have been some commercial products like the Stingos that people have tried using before that helps to limit how much the nematocysts are firing prior to being removed. But for the most part, you just use seawater, right? So that's where they're normally living at anyway. So you can use seawater to try to get off any tentacles that are remaining. Or you can use some other kind of lubricant. Maybe they're not at the beach anymore. I can't imagine they would have traveled with that still on them. But using like shaving cream, any kind of lubricant can be used. And then typically like something like a straight scraping kind of device, like we talk about a Visa, but like any kind of credit card or something like that can be used to kind of scrape off any tentacles or any kind of tissue that may be left over. So in terms of management, if there's only a few antivenoms we have available, most of these you're going to see over in Australia, so things like the box jellyfish. Again, I'm not going to get too much into the dosing or anything like that, but this can be useful if you have patients who are developing like really severe arrhythmia or respiratory depression or anything like that. And I've also seen that for patients who are having arrhythmias, things like verapamil, magnesium have been effective. So most of the time it's going to be symptomatic management. For this one in particular, there happens to be an antivenom. Next, there's several fish that you would have to worry about getting stung. You typically will see that this is either going to be people who are maybe out in the water, maybe they step on one of these fish, or you more frequently see it with handlers or people who will keep these fish as pets in their aquariums, especially when you see that with like the lionfish here. So you can definitely see a lot of stings that happen from that. Typically with things like stingrays, if you step on one of them accidentally, that's where they have a barb that can actually whip up and actually hit the patient. That's where most of those envenomations occur. So more often than not, though, you see if there's any deaths associated with these, it happens to be due to trauma, not necessarily the venom that's injected. If you recall, like Steve Irwin, he actually ended up dying from trauma due to a stingray sting, right? So in terms of the spiny fish, though, this is frequently where collectors end up getting stung here. And you do find a lot of these out off the Gulf Coast and in the Florida Keys. And the majority of the calls we actually get are the lionfish. And mostly it's people who are handling them in the aquarium and they end up getting stung by one of the barbs that it has on there. And so you can see that it releases, depending on the type of fish you're dealing with, or it be a stingray or one of these Scorpandiae, basically they can cause severe pain at the site of injection. Interestingly, here you can see the stingrays are actually having things like phosphodiesterase and 5-HT, serotonin and other amino acids. You can see things like vasoconstriction and bradycardia, all kinds of cardiovascular issues. Very rare you would see this though, right? Maybe you had a very small patient being injected by a very large stingray maybe, but for the most part you're just going to get local pain, erythema. Really, wound care is going to be the best thing for them. The Scorpindia, they can actually have several different types of toxins that are out there. So things like Stonius toxin, there's Verruca toxin, and Trecnilacin, and basically they all have their different actions here. So for instance, like the Stonius toxin can cause things like hemolysis, right? You can see things like different cardiac effects due to blocking calcium channels due to the Verruca toxin. So it's variable depending on which type of fish you're dealing with and what kind of clinical effects you can see there. But it's for the most part pretty mild pain at the site of injection in a lot of cases. But again, when you see patients who have ever stepped on a stingray, again, if you ever watch, there's YouTube videos out there, you can see this where you can actually end up seeing the barb actually whip out of the stingray itself. And again, that's where you can see that it will inject the toxin, where you can see things like local injury, necrosis, and ulceration that can occur there. For the stonefish, they're going to cause a lot of immediate pain, and you can actually end up finding, due to some release of those things like amino acids and whatnot, you can find that the wound will get very cyanotic and edematous, and pretty slow healing for the most part. And rarely we see these other systemic effects like seizures and whatnot. In terms of management, frequently one thing you want to consider, especially if patients are showing up at the ER, is to get a radiograph. You want to make sure to see if there is any foreign material left over that, one, could be causing physical injury, two, could be causing more release of the venom potentially, and so you want to get rid of that if possible. And actually in stingrays, they've actually required surgery in some cases. So again, obviously outside of my scope, but again, it's good to get that consult in. Tetanus prophylaxis, and one of the interesting things we can actually administer for these patients is to submerge wherever it was stung, so whether it be the foot or the hand or something like that, submerge it in as hot as water as the patient can actually stand. The reason why we do that is it actually helps to denature the venom that has been injected into the patient and helps to eliminate the systemic effects. So hot water is really going to help out with that. There is a stonefish antivenom. Again, very rarely you'd ever run into this, but that is one we do have available for those particular types of fish, for the stonefish. So I think that's it for my topics here. It's kind of quick, but it was kind of a hodgepodge of different topics there. Do you guys have any questions that I can answer for you? And this is actually the end of the material for Pharm 2. So congratulations, you are practically done. Okay, so let me see, pull this up. So a couple questions. So back to the antivenom slide on the last lecture. How deeply should we understand the difference between Crofab and Antivip? More so just know that it's available. We have two different products. I'm not going to ask you specifically which one's the Fab 2 versus which one's the Fab. I would more like you to know, when do you give it, right? You don't give it to every patient that says, oh, I got bit by a snake. Make sure that you can identify which ones are going to be venomous versus not. Make sure you know indications on when to give it. Because I will tell you, I forgot to mention it last time, but like Crofab, extremely expensive. I think for the last time I checked, I believe it was $1,800 for one vial, and then you're given between 4 and 6 to start with. And then maybe following up with another 6 for all the maintenance dosing. So, I mean, it can get pretty expensive pretty quickly. And so, when we get calls on this, it's not because, the providers don't know how to manage it. It's more so that they can get kind of our blessing to say, yeah, this is probably needed. We should go ahead and administer it, because it is such a big cost issue there. So that's more the thing I'd like you to know. So the antivenom is being produced now. I'm assuming you're talking about the coral snake. And yes, now it is being produced again, the same equine source. Actually, kind of interesting is we have had shortages before where we have patients who are bit, they're getting symptomatic, and we did not have any available to us because the hospitals just didn't have any access and anything that's local. We ended up getting a antivenom from South America that was for their coral snakes, and there's enough homology between the venoms between North American and South American coral snakes that you could actually use the same antivenom, and so that was one thing we've used in the past. Obviously, anytime you use a drug that is not approved in the U.S., you have to have them sign all kinds of releases, and you have to go through this investigational new drug process, and it's a big pain in the rear, but that is something that you may see occasionally, especially if you're getting to work in an ER or something like that. I've heard that we can use the venom from certain animals, i.e. marine snails, to create certain drugs. How does this work? Is it like how they have vaccines with weakened strains of the virus? I'm not familiar with using a marine snail to form a drug, but it depends on kind of what you're looking for. I mean, if you think about it, we got some of our anticoagulants from leech spit. We have our incretin mimetics came from Gila monster spit. There's different animal sources. I mean, we get calcitonin from salmon sperm. So there are always different ways we can get drug sources from different types of animals. It could be we can isolate out what a specific component of this extract is and figure out, try to isolate that and find a synthetic way to produce it. Who knows? But that's something I've not heard of. So if you have any more information, I would love to see that. It'd be kind of neat. There's a lot of sea critters we need to know about. What kind of questions would you ask regarding, say, the last 20 slides of this lecture? I mean, any and all facts are possible, right? So just know everything. No. I would know kind of basic management. Like, if you had a clinical case that came up and it said this patient was stung by X, Y, and Z, like, what are the things you should try to do, right? So if it's like, if it was a stingray envenomation, say a patient got, was in the ocean, they stepped on a stingray and it stung them in the calf. Now they're coming in complaining of severe pain. What would be your next step of management? Could say like, submerge the limb in hot water. It could say, urinate on it. It could say a couple different things. You need to know, okay, yeah, for a stingray, yeah, it makes sense. Let's go ahead and submerge that in hot water, right? So it'd be kind of things I would expect you to kind of pick out from that. You have to know every single clinical effect possible. No, but you should at least know how, in general, kind of what these patients may present like based off of kind of what we talked about today. Let's see, any other questions or anything? I'm not really seeing much in the chat, but maybe my chat's not working. That could be possible. Anything else? Oh, my chat was not working. Let me see here. Okay, looks like we're wearing a green sweater. I don't know who's wearing a green. Oh yeah, the little caterpillar did look like it was wearing a green sweater. Should we know about common scientific names of the animals for the exam? No, I would just give you the name of the animal. I wouldn't expect you to be able to recognize if it was a Scorpendiae versus, or I wouldn't put like the scientific name for the snakes or something. I would say it's a eastern diamondback or it's a cottonmouth or something like that. Why can't we use heat against snake venom? I don't know if they've ever tried that before, but you've already got a pretty pretty nasty injury already to the site. I don't know if heat would actually help out at all with that. The other thing you have to think about is like when these venoms get injected, it's not like it's depending on where it gets injected to, you can see kind of slow absorption of this venom systemically, and so it can actually depend on where it injects it. So for instance, if it was just into like the subcutaneous tissue, you may actually find some lymphatic drainage would eventually lead to that becoming more systemic. Versus there's been some cases where a snake bite will actually get into like into a vein and directly inject it into an intravenous site, and that can be really bad. That can actually lead to cardiovascular collapse in some cases. So that was pretty significant. So it really just depends because you have to think about how this stuff gets absorbed. So with the heat thing for the snakes, it really wouldn't help out. May do something for the local effects, but it wouldn't really do much for the systemic effects. I can't imagine that would be anything there. Plus, snakes live in Florida where it's hot, and it doesn't denature their venom, right? So maybe. Just kidding. I see Andre asked, do we have any more classes with you? You actually do have a few more classes with me, I think. So I will be dealing with you for your pub skills and research methods. I guarantee you will probably like that class, not as much as you like learning about snakes and stuff, but it's fun. That'll be where we do our research paper and write all of that. And then I'll have you for all the grad projects and stuff, so I'll certainly still be around. Oh yeah, we do have one more class for tomorrow, so that's going to be the review. Recall that we're going to do that on Kahoot, so I will send out an announcement. I'll have the link on there, and so we'll do the Kahoot review. That'll be on Zoom. I don't know if I mentioned, I said Kahoot instead of Zoom, so that's going to be on Zoom, and I'll put the link for that. That way we can all participate together in real time, because I know this has a bit of a delay, so we'll do that, and everyone should be there for that one. I think that's it. So any other questions or anything? And congratulations on finishing up your farm curriculum. Next, it'll be Clin Farm in the summer with Professor Q, and you might see some of us pop up for a few guest lectures here and there. I know I do one for like fluids, and then we have one that I co-teach with Professor Lack, so you may see me here and there, depending on how things go. All right, well, if not, I will see you all later. Have a great day, and I'll see you tomorrow.